Firstly, we're going to learn about pelvic trauma. For pelvic trauma, the mechanism of injury can be due to motor vehicle crash, motorcycle crash, pedestrian vehicle collision, direct crushing injury, and also fall. Pelvic trauma can be classified as anterior-posterior compression, or we always use the word open book pelvic fracture, and then lateral compression, vertical shear, and also combined mechanism, any of the three. Anterior-posterior compression injury or open book pelvic fracture is a significantly disrupting the pelvic ring injuries, which combine an anterior pelvic injury and also posterior pelvic fracture. So it causes a widening or opening of the pubic symphysis more than 2 cm, and also it causes ligamentous injury or disruption of the sacroiliac joint. So the bleeding can be very severe and also life-threatening in this kind of injury, and it happens around 15 to 20%. Next is lateral compression injury. It happens when a force is directed laterally into the pelvis, and this injury is the most common mechanism of pelvic fracture that happen in a motor vehicle collision. So the mechanism is the hemipelvic will rotate internally, and this can cause the pubic to go into the lower genitourinary system, and this can cause injury to the bladder and also to the urethra. But this injury rarely cause death, but if it is do happen, it will cause very severe morbidity and also a permanent injury. The third mechanism is vertical shear. It is the least happen because the frequency is around 5 to 15%. What happened is it is caused by a high energy shear force, especially if the patient fall from height more than 12 feet. It causes disruption of the sacrospinous and sacrotuberous ligaments, which will disrupt the iliac vascular and cause severe hemorrhage, and also will cause major pelvic instability. How to approach a pelvic trauma patient? Again, you have to go to primary survey, adjunct primary survey, secondary survey, and adjunct secondary survey. So in primary survey, you always have to check the airway, breathing, then only go to circulation, disability, and exposure. So if the airway and breathing is clear, then you go to the circulation. You need to resuscitate the patient with fluids because the patient is bleeding, because in pelvic area it can cause up to 2 to 4 liters of blood loss. Okay, so you need to fluid resuscitation, and also you need to control the hemorrhage, control the bleeding by apply a pelvic binder, because the pelvic is unstable, so you need to stabilize the pelvic by putting the pelvic binder, and the pelvic binder also function as to reduce the pelvic volume and stabilize the fracture fragments. Okay, and then you proceed with disability. You look for the GCS, and then exposure. Look for any limb length discrepancy, indicates any pelvic injury. And don't forget to examine the back and do a digital rectal examination and so assess the neurology. Then you go to adjunct primary survey and also adjunct secondary survey, which here you can do your focus assessment of sonography for trauma, and you do your pelvic x-ray, and lastly you do the CT pelvic. This example of pelvic binder. The above picture is a SAM spleen, and the lower picture is using a sheet as a pelvic binder. Pelvic binder or sheet can produce sufficient temporary fixation for unstable pelvis when applied at the correct place, which is at the level of the greater trochanterus of femur. Technique is you slide the device from caudal to capsular, and then you center it over the greater trochanterus, and two people on opposite side will grasp the device at the bottom and top and shimmy it proximally into position. If you use a sheet, you cross the limbs of the sheet and secure with clamps or towel clamp.